Your conference is being recorded.
Hi, good afternoon. This is Nada Harik, and I am here today to talk to you guys about measles and what is going on here in 2019 with obviously the outbreaks that you have been hearing about in the news and how it affects us. So we have a few learning objectives for today's conference. The first one is to recognize the clinical presentation of measles. If you are like I am, then you have seen very, very few or even no cases of measles, so I think it's very important for us to review the clinical presentation. I want everyone to be able to appreciate the importance of vaccination and infection control measures and limiting the spread of measles, which is obviously preaching to the choir to you all, and then describing some strategies that can be implemented in the outpatient setting to prepare for potential measles cases in your practices. So I wanted to just start off with some data showing you what's been going on in 2019 with measles in the United States. I think you guys have seen this or know of it, but this data is available on the CDC website. At the end of this slide set, I actually have a slide that has links to many different websites with fantastic information, and one is to the CDC measles page. So you can access this data and see the updated data, which gets updated weekly by the CDC if you want to use it in your practice or share with patients. So this is just to show that we're having a banner year of measles in 2019. You can see we're already up to 764 cases. Our last kind of banner year was in 2014. Again, this is just a great resource to be able to see how many measles cases we have circulating. Also, another wonderful resource available on the CDC measles webpage is a map of the United States showing where we're having outbreaks here in the United States. They also have links to the WHO that gives information about international outbreaks, and also those are just listed on the CDC website as well. Now I'm showing you a little bit of a different map today. This one is actually one I borrowed from the New York Times, and it shows the places that we've had outbreaks, but I liked how they used the size of the circle to represent the size of the outbreak that we've seen so far in 2019. You can see that there have been cases of measles scattered all across the United States, with the biggest outbreaks being in Washington State and Oregon on the West Coast, and then on the East Coast, our neighbor in New York with 102 cases in Rockland County, and then between Kings County, where Brooklyn is, and Queens County, where Queens is, 367 cases. But this is just a great resource for kids that come to clinic that may have traveled, or you can just pull it up and see where we're worried about measles right now in the United States. So let's talk about the clinical features of measles. Measles is an acute viral respiratory illness that begins with a 2 to 4 day prodrome of fever, malaise, and then those 3 C's, cough, coryza, and conjunctivitis. The fever can be as high as 105 degrees Fahrenheit with measles. And then another clinical feature I wanted to just point out is that the conjunctivitis with measles is that classic conjunctivitis that we see where the eyes are red, they can be very watery, they can be itchy, and we can have a lot of sensitivity to light, so patients may present with photophobia as well. As measles is really contagious and our goal is to prevent the spread of measles, it's really important for us to diagnose it as soon as we can. So this prodrome that we see with measles really may be the single most helpful finding in diagnosing measles. But in order for it to be helpful for us, we really need careful documentation of the history of this prodrome, because none of the symptoms I just talked about, fever, malaise, cough, coryza, and conjunctivitis, necessarily distinguish measles from multiple other viral illnesses. But the duration of the prodrome can be very helpful. It would be unusual for a child that has measles to have a prodrome duration that is less than 2 days. So if we have a child and they develop fever and rash on the very same day, or they have rash that appeared the next day after a fever, then it's unlikely that we have measles. Now, in this prodrome period, that is when, if we find it, we're also going to see the pathognomonic enanthem of measles, which is Koplik spots. The Koplik spots typically begin 48 hours prior to the exanthem, or measles, typical measles rash that we see. So what are Koplik spots? They're 1 to 3 millimeter whitish or grayish or bluish kind of elevations with an erythematous base that are seen typically on the buccal mucosa opposite the molars. They can spread, though, to cover all of the buccal mucosa, as well as the labial mucosa and the hard and the soft palate. Now, these Koplik spots generally only last about 12 to 72 hours. So while we do consider them pathognomonic, they can be less helpful than that prodrome that we just talked about, because they don't appear in every single patient that has measles. They're often gone by the time the rash appears with measles, and they're really kind of hard to see. I am going to show you some photos in a couple slides of what Koplik spots look like as well. So then after our fever begins, 2 to 4 days later, we'll typically have the rash that we see with measles, and it's a classic erythematous maculopapular blanching rash that classically begins on the face and then spreads from the head down and also outwards to involve the neck, so from the face to the neck to the upper trunk to the lower trunk and then to the extremities. The incubation period of measles is 7 to 21 days after exposure, although symptoms typically begin 8 to 12 days after exposure. And then the average interval between the appearance of a rash in the index case of measles and subsequent cases is 14 days. Now, the key to remember with measles is that patients are contagious from 4 days before the rash to 4 days after the appearance of the rash. So it's important that we make that diagnosis early and, again, use the prodrome and our history from the prodrome to try to figure out if someone truly has measles or not. So here's some photos taken from the Red Book Online of Koplik spots. Again, you can see those white lesions with an erythematous margin just across from the molars, and 2 different photos there for you guys to look at. And then wanted to show some pictures of the rash and some of the other findings that we see with measles as well. So this first photo has a 6-year-old little girl that has the early rash of measles as well as conjunctivitis. So we can see her red eyes and that they're quite watery, and then that rash beginning on the face and not yet even really spreading down towards the neck and the upper trunk. While on the other panel, we have a child that has measles with the rash being present for 3 days. So this is a photo on his 3rd day of rash, and you can see that the rash is on his face and then has spread down the neck to the trunk to his extremities as well. Just some more photos for you guys to see the facial rash, the conjunctivitis, and then the runny nose that we see with measles. I think this picture down here is particularly representative, as we can see the watery eyes and also that snotty nose that we can see with measles. And the other important thing to keep in mind is none of these kids look particularly happy. Measles is not a fun virus, and so they usually don't look very well. More photos of measles here to focus on the rash, so you can see what that looks like and how it can often coalesce in various areas. And then just one more photo taken from the CDC. On the CDC website for measles, they have a great link to a provider toolkit where they have all kinds of images and signage that you can use in your practice. And I took this from that measles toolkit, just showing the rash and that we need to consider measles when we have a patient presenting with a febrile rash illness and clinically compatible symptoms that we just talked about. Okay, this is from a handout that was made available by the New York Department of Health. It's also very easy to find on their website and can be used in your clinics, like in a back room or above a work area. And I liked it because it shows some pictures of rashes of various infections or diagnoses that are on our differential, and we're thinking about measles, and then just gives a few key characteristics as well of the particular processes and how they vary from each other. I'm not going to go over these in detail, just wanted to leave this on here as a reference for you all and to let you know that that handout is available. And this is the second kind of part of that one-sheet handout, showing other things as well that are in our differential for measles, including Kawasaki's and Fifth disease, as well as roseola. This is, I think, a fantastic photo that was shared with me by Dr. Bud Wiederman from an old edition of Krugman's Infectious Diseases of Children's that shows some drawings illustrating the differences in appearance and distribution and even progression of measles versus rubella and scarlet fever. I like that in measles it shows us what we expect to see on the first day of the rash, with maybe the buccal spots still present on the buccal mucosa, although starting to fade, and then maybe just some discrete rash on the body, but certainly on the face, to what we see on the third day of the rash, similar to that photo that I showed you guys from the Red Book, where the rash is now spread. Compared to scarlet fever, where we see different progression of the rash and also have different symptoms. Then to go along with that, Krugman's also has this great schematic of comparison of fever, as well as the symptoms that we see with measles, with, again, a few other things that are on our differential diagnosis. Here we've got the days of illness. We've got temperature, so we can look at that, how that fever curve changes. And then we've got some of the symptoms that we talked about, so rash, Koplik spots, conjunctivitis, coryza, and cough. We can, compare measles with something like roseola, where we have a high fever initially, the fever resolves, and then the rash appears. Where we have measles, or we have a rash, where we have a fever that is slowly rising, and then rash appears. Fever often hits its peak after the rash has appeared, and then slowly we have defervescence. And just an up-close picture of that. Schematic for you guys to peruse later if you'd like. So I want to show this video from the CDC. It's a great video that's going to show us some more pictures of kids that have measles and review a little bit of this information that I just mentioned again. I do like this because it is one of the few photos of measles rash in a child with darker skin. Those are not easy to find online. And it's just important to remember that rashes can often be difficult to see in individuals that have darker skin. That erythematous, base for these rashes are often a little bit harder to see. So let's play the video.
The clinical features of measles are fairly distinct, at least after the rash appears. Unfortunately, most of the transmission takes place before the rash appears. After an incubation period of 10 to 12 days, there's a stepwise increase in temperature to 103 degrees Fahrenheit or higher. What usually follows is the classic triad of cough, coryza, or runny nose, and conjunctivitis, or pink eye. An astute observer may see Koplik spots, a rash found on mucous membranes, a day or two before the Contagious rash. This prodrome usually lasts 2 to 4 days. The rash appears about 14 days after exposure. It's caused by deposits of measles antibody in the skin. The rash is maculopapular and appears first on the face. During the next 2 or 3 days, it descends to the trunk and then to the arms and legs. The rash fades in the order of appearance. You may have seen measles when it was more common
I'm going to go ahead and pause the video there. If there were individuals who couldn't hear that very well, there is a link embedded in these slides, which are going to be available to that video, so you can watch it later or share it with others as well. I'm not going to let it keep rolling about what he has left to say about testing, because we're going to discuss that later in this talk. I just wanted to put in one quick slide about this serious nature of measles, because we often get questions about this from our patients and their families. About 1 in 4 people who get measles will be hospitalized, and about 1 in every 1,000 people with measles will develop encephalitis. About 25% of those children will have neurodevelopmental sequelae. Now, people who are at the highest risk for having severe disease and complication from measles include infants and children that are less than 5 years of age, and then adults that are greater than 20 years of age, pregnant women, and then people who have significant immunocompromise, like having leukemia or an organ transplant, are also particularly at risk. Subacute sclerosing panencephalitis is also a very serious complication of measles. It's a fatal progressive degenerative CNS disease. It typically occurs 7 to 10 years after measles virus infection. And then I think an important thing to remember is that 1 to 2 in every 1,000 people with measles will die. I think looking online recently and hearing what people have to say about measles, they often say, oh, it's not that serious. We've been having all these cases in the United States, and we haven't heard about anybody who has died yet. But we haven't had 1,000 cases yet in the United States, and it's usually that number of 1 to 2 in every 1,000 people with measles will die. And earlier outbreaks that we had in the United States, including in the 1980s, we had multiple deaths in children. So just remind people, certainly measles can be serious. Now, as you all know, measles is very contagious. 9 out of 10 people who are susceptible to measles, who have close contact to a measles patient, will develop measles. It really is one of the most highly communicable of all infectious diseases, and likely the most contagious infectious illness that I'll ever see in my career. So we really want to take quick action to limit secondary cases. Measles is transmitted by direct contact with infectious droplets or by airborne spread when an infected person breathes or coughs or sneezes. And the important thing to remember is those measles virus particles, when that person breathes or coughs or sneezes into the air, they can remain suspended in the air for up to 2 hours. This is part of the reason why measles is so highly communicable. Patients with measles, as I mentioned previously, but I keep wanting to stress, are contagious from 4 days before the rash until 4 days after the appearance of the rash. So what do we want to try to do to limit the spread of measles? So one of the most important things is to avoid the unnecessary exposure of high-risk children to measles. So obviously, if we have a concern for a complication related to measles, if we are concerned a child is significantly dehydrated, or they have seizures or encephalitis or pneumonia, another complication that we can see with measles, then we may want to make a transfer to a higher level of care. But in general, we really want to avoid exposing those high-risk children, for example, that we have at Children's National Medical Center who may be immunodeficient to measles. So I really want to stress that we do not want to transfer or refer a patient to CNMC just to confirm the suspicion of measles in a fever rash patient, or just for testing of measles. Again, if there's a concern for a complication, certainly, we'd be happy to see the patient and assess them at CNMC, but in that setting, you want to always make sure to notify the emergency department and infectious diseases before transferring that patient to Children's National, so that we can take all of the precautions we need to on our end to arrange that someone is there to meet the family outside the hospital and put a mask on them, or to remind you to maybe give them a mask if they're already in your clinic. They should already have one on, but in case they haven't, and to make sure to wear that on their way to come see us at Children's National Medical Center. Also, obviously, we want to avoid any unnecessary exposure of your office patients to children with measles as well. And towards that end, recently Dr. Wiederman came up with a fantastic tool that he created for the Children's Practice and Associates clinics with the help of Dr. Ellie Hamburger and myself and Dr. DiBiase to see what we can do to protect clinics by triaging patients who may be calling you with fever and giving advice about whether they actually need to come in to be seen in clinic because we want to see if there's any concern in that febrile child for measles. So this triage tool, which we have here on the slide, which can be made available to all of you as well in case you'd like to use it, is a protocol that should be used in addition but not in place of standard telephone protocol for families calling for advice on febrile children. Again, it's intended to avoid unnecessary exposure of your office patients to kids that have measles. And it's not perfect. There is no actual tool that really helps us differentiate measles from other infections or other processes, and this is just kind of what we came up with right now for us in the local area. Luckily, we don't have any outbreaks going on right now in the DC area, although there was a recent outbreak of 4 cases in Maryland that you all probably know about. And so some of these screening questions and actions that we would take would likely change if we were in an outbreak setting or had more cases in this local area. But for right now, we thought this was the best kind of questions and then actions with what we're dealing with currently. So it starts with asking if your child has a fever of at least 100.8, or if the family didn't take their temperature if the child feels hot. And if not, then you would just proceed with your normal screening. If yes, then the telephone triage person would ask some second-tier questions, and then depending on the answers to those second-tier questions, then that telephone triage person should involve the clinic MD to assist. So talk to the family more, ask further questions that would determine if the child has measles and what the next, or potentially has measles, and what the next steps would be. So the second tier questions involve if the child has been vaccinated or not. The definition of an acceptable vaccine history is here. Exposure, so we want to know if there's been any exposure to a known measles case, or if the child has gotten a letter from the Department of Health or looked online and saw they were at a certain area where there had been a person with measles, or if there's been any travel within the past 4 weeks. And that would be any international travel or travel to an area where we're having a U.S. outbreak. And those are listed over to the side in box A with a link to the map so that we can update those if there are new outbreaks across the United States, which unfortunately there will likely be. And then some questions to ask about the clinical findings, so asking about that prodrome of cough, coryza, and conjunctivitis with some details that it usually occurs 2 to 5 days prior to the onset of the rash and what the symptoms are, and then asking about a rash and a little bit of a description of where it begins and how it spreads that we already talked about. So the actions that are to be taken based on how we respond to those questions is if we have a child that's greater or equal to 12 months of age and has had no MMR vaccine and has fever, then we suggested that the telephone triage person involve the MD to get on the phone with the family and ask more questions to see if there's a concern for measles. If there is a positive exposure history, regardless of the MMR vaccine history, the MD should also be involved. And then if there's an acceptable vaccine history, no exposure risks, but the child has fever and either rash or eye symptoms in addition to the fever, then an MD should be involved to ask more questions, screen, and make a decision based a little bit about what we talked about for the symptoms, if measles is truly a concern or not. If after a discussion with the family over the telephone, there's concern that this child has measles, then we suggest that the MD ask the family to stay put. Office appointment should not be initially made to any of these children, and certainly not in that setting. And then the physician can call the local health department to discuss the patient and get instructions on what to do, especially instructions about testing. The health department can advise about if the child should be coming to the clinic or if they should stay at home, and the health department can go out to do the testing. So that all can be discussed with the local health department, and certainly we can be called as well to discuss if there's concerns about, is this a child I should be worried about with measles, or to give further advice on what to do. And again, as we mentioned previously, if there's a concern that this is a very ill child who does need to be assessed further, outside of the office setting, then we would need to be notified if this was a child that was ill that needed to come to a higher level of care if they were coming to us, or to notify whatever local emergency department you would be referring that child to. We'll talk a little bit later on, but maybe some potential actions if you decide the child needs to come to the office, or the health department tells you that it's best served if the child comes to your office to get screened and to get tested. Actions that you can take are to, for example, schedule that child as the last child of the day or in off hours, so that there'd be less risk of infection to others. Certainly, if you know the child is coming, you can meet them outside with a mask, and even potentially do the testing that you need to do outside of the office, in the parking lot, or just outside the building. Those are all actions to help mitigate the potential spread of measles if that child does indeed have measles. Okay, so let's talk a little bit more about infection control in the office practice setting. If you do determine that child needs to come to see you in the office, or if a child just happens to come into the office and didn't call first, and you're concerned that that child does have measles, what you want to do first is just immediately place a standard isolation mask on the patient. Not the mask we have pictured here, that's an N95 mask that I'm going to talk about later for providers, but just the standard, if it's a child size mask, if it's an older child, or an adult size mask. Or if we've got an infant and we can't put a mask on them, we suggest covering the infant and their face with a blanket. And then placing that child immediately in a private patient room with the closed door. Now, obviously, if you're in a practice that has a negative pressure room, that is preferred if it's available. It's just unlikely to be available in most office practices. And then the staff or the healthcare provider that's going to go in and evaluate this patient and see the patient should be a healthcare provider who is immune to measles, and we'll talk about the definition of what that is for a healthcare worker in a moment. But they should wear either an N95 mask or a PAPR, and I have pictures of those here. This is what the N95 mask looks like. This is what the PAPR system looks like when they're interacting with that patient. That's what the CDC recommends for immune healthcare providers. N95 masks are much cheaper than this system, but they need to be properly, or have someone do a fit test if you're going to wear them, to make sure that they're properly fitted and effective. So that's sometimes a little bit harder to coordinate for clinic practices to have these masks and then make sure that everyone who would need to wear it is fit tested and know that it fits well. Maybe having one or two PAPRs just available in the clinic to be worn if needed is something a practice can think about doing. This would also be helpful for other infections as well, like varicella or tuberculosis. So maybe not a bad thing to have in your practice. Then you immediately want to notify your local Department of Health that you have a child with possible measles. so you can get further instruction on what to do with that child. And if you're in the hospital, if your clinic is associated with a hospital or in a hospital setting, be sure to also notify your hospital infection control right away, as well as infectious diseases. And then, as mentioned previously, you can contact us by phone for further guidance as well. So this is just a reminder again to use that airborne precautions before you examine a patient with a possible measles. Also, I wanted to remind you this child here does not have a surgical mask on because the physician is looking in their mouth, hopefully to try to find some complex spots in there. When you have your patient in the room, they should continue to wear the mask the entire time they are in the room. When they are leaving and exiting the room, they should continue to wear the mask. If they send them to X-ray, they need to wear the mask. The only time a child with suspected measles or known measles can take a mask off in a room is if they're actually in a negative pressure room, an airborne isolation negative pressure room. So that's the only time they can remove the mask. Now, that does make it a little bit tricky in terms of doing your examination like we just mentioned. So, you may want to think about meeting them outside to look in their mouth and do the testing that we need to do, because, you can't look for complex spots and do the swabs that we want to do necessarily while they're wearing a mask. Maybe you can take off the mask and cover them and yourself with a blanket. We got to be creative when we're trying to do these things in a non-airborne isolation room. The other thing to remember is that we talked about measles virus remaining suspended in the air for up to 2 hours after that patient has been there. So the room occupied by the suspect case should not be used. The door should remain closed after that patient leaves, and it should not be used for 2 hours after the patient's departure. So again, like we talked about, it's best to see these patients for the last patient of the day or after hours, because not only is the other folks that are in clinic that day at risk, but also based on ventilation systems and circulation, everybody in the building can potentially be at risk as well. So you want to try to see these individuals if they call you before to make an appointment, at off-hour times when there's no one else there to hopefully infect. Okay, so a little bit about healthcare providers and if they're considered immune or not. I alluded to this on the last slide, but healthcare provider evidence immunity is different than it is for the general population, so I wanted to review that. So there's only 3 things if you're a healthcare provider that can count as evidence of immunity against measles, and only those healthcare providers that have evidence of immunity should enter a room where there's a patient or evaluate a patient with suspected measles. So that is somebody who has documented 2 doses of MMR vaccine. So you got to dig up your old shot record and bring it in to show that you truly have had 2 doses of MMR vaccine, or someone with a serologic evidence of immunity, or if they've had laboratory confirmed infection. So the important and key step here that we can take in advance is to ensure that all of the healthcare personnel at our facility or practice do have evidence of immunity to measles, and also that information is documented and readily available. If an individual needs another dose or 2 doses of MMR vaccine to show that they're immune, that should be done now, or if they need to have testing because we don't show documentation, so we need serologic evidence, that should be done as soon as possible before we're hopefully it won't be, but in an outbreak setting in our region. All right, so what can we do to help prevent the spread of measles? So obviously we can be vaccine advocates. I think we all already do an amazing job at this. Pediatricians are on the forefront of vaccine advocacy, but in your clinics, you really want to ensure that all your patients are up to date on their MMR vaccine. We can use a telephone screen like I showed earlier, or a screen at office entry for fever or rash-like illness, and then obviously we want to isolate those suspect measles cases immediately, like I just discussed. You can also use some signage at the entrance of your office to have a sign and a box of masks right there before people even come in, or maybe even outside your building if you share a large building, or in the lobby, saying, hey, stop, if you've got fever and you've got a cough and a runny nose and red eyes, put on this mask. Not a bad idea during respiratory viral season as well to be doing that. As mentioned in the CDC video as well, we really want to be thinking about measles if someone has had recent travel abroad or to a U.S. outbreak site. That's why in our telephone triage tool that I went over, those things are particularly called out. In unimmunized patients, or if you've someone who has contact with someone else who had a febrile rash illness and then, got sick, in that incubation period that we discussed earlier, then we need to be thinking about measles. Again, we want to immediately contact the local health department to report any cases or any suspected cases, and to obtain assistance with submitting any specimens for testing. I wanted to just show this information, again, that was provided by Dr. Ellie Hamburger, the Medical Director of Children's Pediatricians and Associates, about what their group is already doing, some proactive steps that you can take with your practice to sit down and say, all right, what can we do? Here are some interventions that we want to do in advance to try to mitigate the damages that we can see if we're in a measles outbreak setting. Things that this practice or the practices are doing are already working on some proactive outreach. To look through their patients' charts and get their immunization records and see if patients' records are up to date, and if they're not, to make sure that they're updated, like if it's a new patient to your practice, and if it's a patient who's not up to date, to actually reach out to them and say, hey, we noticed you're not up to date on your MMR. Can you come in and get your MMR vaccine? We want to make sure that you're up to date. They are, I think, working on putting some alerts in charts, so that if there's a child who comes in who is not up to date, it is going to be flagged right away. So maybe they'll put a mask on that child just right away, as they're a higher risk for potentially having measles. They're going to be using a script for their triage nurses. I showed you that a couple slides earlier to try to determine if maybe there's some children who should not be coming into the office because their risk of measles is high, and we want to try to arrange testing at home, or talk to the health department and see what the options are for that, or to make sure that we get those kids into clinic, later in the day, like we discussed. We're not in this situation right now locally where an early immunizations with MMR is recommended for everybody, but in case it is, what we would do in that process. We talked about having signs at the front desk, so going ahead and putting that signage together with your group. And then, like I mentioned, I would think about also having masks available with those signs, so families can put that mask right on their child, or know to cover their child with a blanket. Also have that information on the sign. Make sure you've got everything you need if you are going to be doing the testing in your office, and we would suggest that all practices have this in case you've got a child in the office that you need to test. So make sure you've got viral transport media. That's what's needed to do the PCR testing for measles, and we're going to talk about that coming up here, but make sure you've got that. The nice thing about viral transport media is that it's shelf-stable for a long time and it's not expensive, so just order it and have it available in your clinic. The swabs that we use to do the PCR, typically those Dacron or flocked swabs, the same ones that we use to do our RSV rapid testing or our respiratory pathogen testing. Those also, should be stocked in your clinic. And then, they already are ahead of the ball game here and are working on having a plan to managing calls from parents of unimmunized patients if there's a local outbreak. So just some ideas of things you can be sitting down and discussing with your practice group. All right, I want to just talk a little bit about vaccination before we talk about diagnosis and testing. Just a quick reminder about MMR vaccination in international travelers, that the CDC does routinely recommend that individuals get vaccination before any international travel. So obviously we've got our routine recommendation that children get 2 doses of MMR, the first at 12 to 15 months of age, and then the second at 4 to 6 years of age. But if you have a child in your practice that's going to be doing any international travel, the CD also routinely recommends that a 6 to 11-month-old get 1 dose of measles, mumps, and rubella vaccine. Please remember that these children will still need 2 additional doses of vaccine at least 28 days apart on or after their first birthday. If that child who is going to be traveling internationally is 12 months of age or older, they should get 2 doses of MMR vaccine separated by at least 28 days if you've got that time period before travel. If not, certainly give them their first dose, and then you'll give them their second dose, in the appropriate time range, because unfortunately a lot of folks don't come to clinic to see us 28 days before their international travel. And then teenagers or adults or even just older kids who don't have evidence of immunity against measles should get 2 doses of MMR vaccine, again separated by at least 28 days before they travel, or at minimum a single dose if they have not gotten any in there, or if they've just gotten 1 dose, get the second dose. All right. Now, what about measles vaccination in special situations like in outbreak situations? So whether we want to give early doses or extra doses of MMR vaccine, the CDC really asks local and regional health departments to make that decision. Right now, the DC Department of Health and the Virginia Department of Health do not have any recommendations for giving additional doses of measles vaccination, but the Maryland Department of Health did post these updated recommendations on their website because of the 4 cases of measles that had been reported in Maryland recently. So you can see here, actually, the recommendation has a lot of gray area. They say healthcare providers should consider modifications to routine MMR vaccination for patients who might be at increased risk for measles exposures. And then they list who are those patients who would be who might be at increased risk, and they're people who live, work, or attend activities in Maryland zip codes that are listed here. Those are the zip codes where the 4 measles cases in Maryland lived or worked or went around to in their time period of being contagious with measles. Also, individuals that are planning to travel to areas in the U.S. that have a measles outbreak, you can consider modification to the routine MMR vaccination, or an individual who might have contact with visitors from areas with measles outbreak. Well, that's what the Maryland Department of Health has on their website right now and their recommendations. And obviously, they just talk about considering modification. So I think this is a good thing to sit down with your practice and say, do we want to do this? Do we not want to do this? Come up with a consensus. Certainly in infectious diseases, we're also happy to give our advice and suggestion. Might get different answers depending on who you talk to, because different ID doctors have different ideas here. Or in general about everything. For me personally, for right now, if I was just having a patient who was traveling and said, oh, I'm traveling to New York State. Well, if they're just planning to travel to Manhattan for a day or 2 or even for a week and not travel to Brooklyn or Queens, then I would not recommend for them to get an early dose of measles, mumps, and rubella vaccine. But if they were traveling to Brooklyn and know that they're going to be in an area right now where we're having that active outbreak, then I might consider giving that modification to the routine MMR vaccination. And on this next slide here, we're going to see what those modifications would be. And so that's for a child that's 6 to 11 months of age to go ahead and give an initial MMR vaccine, and then to remember that those children still need 2 additional doses at least 28 days apart on or after their first birthday. The other options that are available for modifying the routine MMR vaccine schedule are listed here and broken down by age group. So what to do if it's someone who's between 1 to 3 years of age, 4 to 17 years of age, and then adults. And again, my suggestion is to sit down and discuss this with your group, and certainly, we'd be happy to discuss in infectious diseases with you as well, based on the circumstance, if the child should get a modified schedule for measles vaccination. Okay, so just some local data on measles vaccine here. Remember that to disrupt broad transmission of measles in a local area, herd immunity really needs to be maintained above 90 to 95%, really 93 to 95% for us to prevent the spread of measles. So I wanted to show some local data. The first is a graphic from the DC District Department of Health, who reports right now that the MMR vaccine rate for kids from preschool through 12th grade is 92%, so not that bad, pretty good. And then in this chart below, you can see the breakdown based on the type of school, so public schools versus charter schools, private and parochial schools, and then immunization compliance, and then the number of students that are in those different schools. In Virginia, the vaccination rate, again, for kids between preschool and 12th grade is lower. It's 82.6%. Unfortunately, I don't have breakdown by county for Virginia because they don't report that, but that is lower. That's certainly worrisome for an easy and ripe situation for an outbreak, and certainly what we see is certain pockets, sometimes neighborhoods, sometimes just counties, but areas where there is a lower vaccination rate for MMR are the areas where measles can spread like wildfire, like we've seen in New York, particularly in Kings and Queens counties in New York. So there may be pockets in Virginia that are a little bit different than others. In Maryland, again, that general vaccination rate for preschoolers through 12th grade is great. It's 98.6%. And in Prince George's County and Howard County and Montgomery County, you can see the numbers listed there. So that's fantastic for us. Luckily, those 4 cases of measles that have been reported in Maryland thus far as I know, and I just looked this morning on the Maryland Department of Health website, there have been no additional cases reported. So likely that has a lot to do with this high level of measles, mumps, and rubella vaccination in the area. So kudos to Maryland for its high vaccination rate. Okay, I want to talk a little bit about the diagnosis of measles. What you want to do if you encounter a patient with suspected measles for testing. Obviously, we want you to just immediately contact your local health department for testing recommendations. Each health department has kind of different recommendations. I've actually, on the next slide, got some of those recommendations listed for you as a reference, as well as numbers and contact information for the various Department of Health here in DC, Maryland, and Virginia. Typically, though, what we want to do is to obtain serum blood samples for serology for measles, IgG, and IgM, and either a nasopharyngeal, so NP, or a throat swab for PCR. A nasopharyngeal swab is greatly preferred, but a throat swab will be accepted for testing, but again, the NP swab is greatly preferred. What I have shown here in this picture is just a little cartoon of getting that NP swab because I had been told earlier by some providers that that's not something that's routinely done in clinic, and they wanted to kind of see a picture here of the technique of what we do, because this is very different than some of the other swabs we do, like a throat swab. We're not trying to go in just the front part of the nose. We really kind of need to go back there. That just swabbing, in the front part of the nose, that's going to help us to pick up, for example, Staph aureus, so that people are colonized with, but not the measles virus as well. So we really want that swab to get back into the nasopharynx. A lot of the swabs that come in kits have actually a little mark put in the swab on the this flexible kind of tubing, I guess, and it will tell you kind of how far you have to go in to get a good sample. So that's what that looks like. And then those swabs need to immediately be placed in unexpired viral transport media. It's also called universal transport media, to be sent to the health department. Swabs that are in other types of media cannot be tested for measles. The swab typically needs to remain in that viral transport media for at least 1 hour. Sometimes the health department will say, depending on the container you have, you can just leave it in there and screw on the top. Sometimes you need to break it off, but leave it inside there. Sometimes they want you to leave it in for an hour and then remove it and close off the tube and send it in. But definitely you want to make sure you leave the swab in for at least 1 hour. And again, depending on the health department, they're going to have potentially different instructions. It's so important to contact them and let them know you want to send testing, especially because most of the departments of health are going to be doing the health department in the testing in their own health department laboratory. Now, Virginia Department of Health right now does not have any specific information about measles testing on their website. They just say to contact your local health department. On the slide said this is linked to a page where I think by putting in address or zip code, it'll give you the contact information for the local health department branch. And then they have a general number as well that you can call for details. I would assume that they would also want to do the testing in their own Department of Health laboratory, but sometimes the testing does get sent out to a commercial laboratory. The great thing about doing the testing and sending it out to a local, the Department of Health laboratories is that the turnaround time for the result is much faster. So even here at Children's, we like to send the sample to the Department of Health of the area that the child resides in, because we'll get the result back much faster. So for the Maryland Department of Health, measles testing is performed there, and they require prior approval for that testing. That's why you need to contact them first. And there's the phone number for contacting them for more information about testing. And then for the DC Department of Health, they want to perform the testing at the State Public Health Laboratory if testing isn't supported by the institution's primary laboratory. And there's both phone numbers for during the day and after hours, as well as an email address to get in contact with the DC Department of Health. All right, and then to finish up, this is the resources that I mentioned I'd be sharing with you earlier. So I've got some resources from the CDC, just a general measles resource page. This is a toolkit that the CDC has put together for healthcare providers that I think I mentioned earlier. It's fantastic. It has links to photos. It's got links to signage that you can use in your office, talking points, just a lot of great information for healthcare providers. All in one location. This is a link to, again, some photos and then other resources that you could use for signage from the CDC. These are links to the DC Department of Health, the Maryland Department of Health, and the Virginia Department of Health, specifically to their measles site or to a measles healthcare notice that they may have already put out. There's wonderful information available at the Children's National Internet about measles, including frequently asked questions and information that you can share with your patients. And then for those who are associated with Children's National on the internet, there's also a lot of information about measles and links to all of these other sites at the CDC and the Departments of Health that I mentioned previously. Thank you so much for joining us today, and I'll leave it open to questions at this time.